Okay, so our topic for today is to talk through relative energy deficiency in sport, or that's also called REDS, which you'll see used throughout the presentation. I'm going to try to give you a brief overview of the condition, tell you a little bit about what I'm doing in treatment, but then mostly help you identify it in your patient populations so that you can get them support if we do think that they're in a situation where they're underfueled and experiencing the negative side effects from that. So what is REDS? It's essentially inadequate energy intake that has existed for a long period of time. So when we're not getting enough calories, some systems are getting neglected. Our body is really good at adapting to low calorie or high calorie intake and changing metabolic expenditure. And so when we're not getting enough, the body will naturally start to decrease the amount of energy output we have by slowing down the heart rate, reducing total body temperature, changing blood pressure, things of that nature to help to conserve energy. So that's what eventually leads to REDS, and it typically happens over time. So it's not that someone is restricting for 3 days of their food intake and now they have REDS, but we can start to see some of the negative side effects of restricting for 3 days within that period of time. But generally it takes the adaptions for full-blown consideration of REDS. It can take that weeks to months to years for some athletes to actually start exhibiting symptoms of more of a chronic condition. So what are common signs of REDS? Lots of injuries, especially bone stress injuries, are very common. Slower recovery, fatigue, or just having really low energy. Can't keep up in workouts, especially like they used to. Lower performance, slower running times, jumping times, speed, all of those things. Stomach upset is quite common. Micronutrient deficiencies like iron and vitamin D. In females, not having regular periods. And then in males, they would have low sex drive and lack of morning erection. I know that's not always the most common conversations that are happening, but if you have good rapport with an athlete, maybe those things are coming up. So how does low energy availability happen, which is really at the center of REDS, is we're just not eating enough calories. There's a spectrum of things that can happen. So number one, an athlete could have an eating disorder, and that could be impacting how well they're fueling their bodies. Number two, disordered eating. So maybe an athlete is experimenting with a diet, or maybe their family is experimenting with a diet and it's getting trickled down to a teenage athlete. Maybe they're skipping meals. Maybe they're worried about their weight and they're intentionally trying to lose weight. So they're starting to cut out different food groups or cut back on food intake. And then just generally underfueling. So a lot of athletes have these crazy schedules where maybe they work out in the morning, they go to school a day, they work out in the afternoon, and then they go home and do their homework and try to catch up. And so they could be gone from 7 a.m., 6 a.m. till 6 or 7 p.m. and they still need to eat within that period of time, and they have really high calorie needs because they're doing maybe 3 hours of sports in addition to just their normal daily activities and growing. And then in adults, same type of situation. If they're exercising a lot and they also have work, we're gone from the day for a long period of time. So just packing enough and the logistics of that can be difficult. Eating disorders, specifically in athletes, can be really high. In the general population, it's about 2% of the population has an eating disorder, whereas in athletes, this data specifically looked at collegiate and young adult athletes, up to 19% of males and up to 45% of females. So if you are working with an athletic population, you're going to be working with people who do have eating disorders, so it's something to consider. Atypical anorexia, which is anorexia without a low BMI, accounts for up to 25 to 40% of inpatient treatment. So the most severe anorexia cases, they have normal BMI, and that again is a quarter to almost a half of an inpatient treatment population. So it's pretty common for us to not visually see a low BMI with someone, but they still do have anorexia. Up to 80% of females in the United States express a desire for weight loss, so there is a very likely component of disordered eating that could happen in your female athletes. And just different types of eating disorders that we will see: anorexia, bulimia, binge eating disorder, and then ARFID, which is avoidant restrictive food intake disorder, which is a little different than the rest. Well, they're all different from each other, obviously, but ARFID is probably a little less well known. We're not going to dive into that, but it's important just to be aware of that. When it comes to risk factors for eating disorders, why do athletes have such high risk? Well, these factors that I've circled are probably some of the biggest contributors. Athletes tend to have personality traits that lead them to be a little less cognitive. They're a little less flexible cognitively. They may be more concerned with seeking approval and making sure they're doing things right. We've never met an athlete that's a perfectionist, being sarcastic. They're high achievers and they're high performers and they expect a lot out of themselves. They probably have dieted in a sense, whether it's to improve performance or whatever that looks like. And then if we think about an ideal image within an athlete, if I say ballerina, lineman, wrestler, runner, you probably have a specific image that pops into your head with each of those sports. And while yes, body image can tend to revolve around a similar space for a lot of athletes, not all athletes that are performing well or at a high level or just performing fit into that body image. And so being aware of those athletes that may perceive themselves as different or look different than their peers, they will be at a higher risk too. So for eating disorder prevention, if you're working at a collegiate and professional level, hopefully your dietitian and medical team are all working on this collaboratively, but doing a lot of education for student athletes and sport personnel, identifying those who are at risk, establishing just generally a culture of wellness. We're not focusing on weight. We're not focusing on restriction or perfect diets. We're really focusing on being well-fueled, eating a lot of foods, enjoying food, eliminating stigma from mental health treatment, and prioritizing rest. And then early intervention is key to help people be successful with treatment. So low energy availability physiologically impacts a lot of different systems. So if we're not eating enough calories, it impacts almost every single organ system in the body. You will notice there's a two-way arrow from the mental health component to low energy intake and then vice versa. As you can assume, if someone has anorexia, that's going to negatively impact their energy intake. But also if someone has poor energy intake, even without anorexia, that can actually increase anxiety and depressive symptoms. So bone injuries, a lot of GI distress, low energy intake, again, we have to make up for those calories somewhere. And so peristalsis in the intestines will slow down, movement of the food from the stomach to the intestines will slow down, so we get a gastroparesis type of effect. All of that causes a lot of GI discomfort. Decline in metabolism, iron deficiency anemia, we don't see production of red blood cells happening normally. Heart rate and blood pressure will both decline. We can see orthostatics in some of these athletes. We can see delayed puberty in adolescents, and then a decreased ability to fight off infection. So while these are more health-related pieces, these also impact the athlete in their sport. And so I think we can capitalize on both of those things, because if they're getting injured, they're not playing their sport, and that's going to, again, detrain them that they'll have to come back from. Or if they're feeling other of these negative side effects, even like the GI stuff, it really is taking concentration off of the thing that they're trying to focus on, and can be quite uncomfortable. Now, the performance piece, this is what the athletes in my world at least really care about. And I think older athletes have a little bit more broad sense of the health importance. But for performance, this can really help to get more buy-in for the athlete. So power, endurance, strength, concentration, basically everything declines with chronic low energy availability that's leading to REDS. The tricky part of this is that when athletes first start to restrict their nutrition intake, oftentimes performance gets better temporarily. So they restrict their food intake, their performance gets better, positive feedback loop. So what do? I keep restricting, or I try to restrict a little bit more to build on that performance impact I just saw. And so that can lead them down this pathway of REDS. And then when they get to us and we're trying to educate them on what has happened, it can be really hard to get buy-in, because these restriction practices, what they're eating, that has been what has helped them historically. And then now they don't feel hungry because they've had those GI impacts. They don't feel as hungry. So why would they eat when they don't feel hungry, and then potentially negatively impact their performance on top of what they're already experiencing? So it can be a really hard piece to navigate. It takes a lot of education. It takes a lot of trust on the athlete side of things to start improving their nutrition. Now, the categorization of how severe REDS is based off of certain medical indicators. So we have serious medical indicators, we have primary, and we have secondary. Depending on the mix of those, depends on what category of severity of REDS they fall into. The serious medical indicators is basically if they have malnutrition. So malnutrition is less than 75th percentile median BMI for teens. It would be just it would be ideal body weight in adults, which we calculate. If there's electrolyte disturbances, if they have an abnormal ECG, hypotension, orthostatic intolerance, they've failed eating disorder treatment, acute medical complications of malnutrition, which are listed there, and then any condition that's going to inhibit medical treatment and monitoring while they're training or competing. So again, most of these relate to malnutrition. That is an automatic red categorization for REDS. Primary indicators, so if there are hormonal changes, so if we have primary amenorrhea, so we haven't had a period by the age of 15, or clinically low, free, or total testosterone in a male, those are considered severe. Other primary are listed there, again, revolve around the hormonal component. You see T3 in there as well. Bone stress injuries are considered, especially the high risk bone stress injuries. Bone density scores, so that gives you for premenopausal and postmenopausal females what we're looking for. And then negative deviation for growth in pediatrics. I look at this a lot, so I might see their growth chart following normally and then it flattens off or it starts to go downward. That would be a primary indicator. And then an elevated score on the EDEQ, which is an eating disorder examination questionnaire, so an evaluator or a marker for eating disorder, active or risk. Secondary indicators, oligomenorrhea, so they have periods, but they're infrequent. So oligomenorrhea, they're having at least 6 periods in a year, but less than 9, or their periods go longer than 35 days or less than 21 days. History of one low risk bone stress injury, elevated total or LDL cholesterol, and then clinically diagnosed depression or anxiety. And then we take that combination of what risk factors they meet and put it on the severity risk assessment table, which really helps us to communicate with the athlete, especially if and why we are restricting their activity. And so that tends to be the biggest piece that we have to hit home and that we struggle with the most, is we often will need to adjust activity, and often activity that athletes are coming in doing is inappropriate for them. So they may not be taking rest days, or they may be doing 4 or 5 hours of exercise most days of the week, which is not necessary for the sport that in the level that they're competing in. And so doing some education and then making adjustments in that is also going to help us achieve that energy balance that we're trying to achieve. So in an athlete with REDS or hypothalamic hypogonadism, and so the idea of being underfueled and the impact that that has on the hypothalamus, it decreases the expression of hormones through the hypothalamus, which then decreases the expression of gonads in the body. So that's where we see the low testosterone, we see low estradiol, FSH, LH can be low as well. The treatment is nutrition. The treatment is for the athlete to eat more and sometimes likely gain weight as well. So when I'm seeing the athlete, I'm calculating their energy availability if I can, which is the total amount of energy that they are eating. So I would get that from like a diet recall, hopefully a good one, ideally. We would subtract just their exercise energy expenditure, not the whole day, but just the exercise piece, and then divide that by their lean mass. So I do need fat-free mass for this calculation. We get that from our DEXA scans. So I'm able to take body fat percentage and divide that out so that I have lean mass in kilograms. You can also do that through like a bod pod, or you can do the handhelds. Oh my gosh, it's escaping me. BIA, bioelectrical impedance. So you can do that. It's just less accurate. But is it going to be so inaccurate that it's going to largely throw off our numbers? Probably not. So then the definition of low energy availability is less than 30 calories per kilo of lean mass, which is what we've just calculated. Almost everyone has hormonal metabolic dysfunction at that level. Adequate is greater than 45 calories per kilo of fat-free mass. That's in females. And in males, low may be as low as 9 to 25 calories per kilo. So males can tolerate a wider range of low energy availability, which makes sense because they don't need as much fat mass on their body. But that data is still really developing, and we need more to really identify what that level is for males. From the body composition conversation, I don't talk body composition with any of my athletes. We don't have specifics. We don't try to target any specific numbers. And that really goes at all levels of sport. Because when you look at this table, this is all of the graphics in here are from the REDS consensus paper that you'll see at the end in the references. But when you look at this, even at the elite and professional level, most athletes need foundational nutrition education. So they're really starting at the bottom, or if they have foundational, they're still really developing. Like there's still a lot that they could change that help to improve their performance. And so while body composition can be a great indicator of athlete health, so if we see that at a certain body fat percentage, the athlete stops menstruating or stops recovering as well, that's too low. Or if we see an athlete that's been injured and they're returning to play and their body composition is still not back to where it was when they were playing normally at their healthy weight, we know that they're probably not quite at the level that we would expect them to be at, right? But using it as an indicator to like manipulate body composition is not helpful. And really, we would only have that discussion in an athlete who has a perfectly healthy body image and a perfectly healthy relationship with food. And if I'm being really honest, I have not experienced that person in my own practice after working with athletes for over 10 years, almost 12 years now. So I think there is enough ideals around body image and ideals around food and composition that talking about that is not usually in the athlete's best interest. It's more in the athlete's best interest to focus on fueling and their performance metrics as opposed to specifically their body composition. And I know that gets tricky when we start to talk about like weight class sports. That's kind of a whole nother beast. But let's think of outside of weight class sports, this is really what we would focus on. So my message to athletes is really, we need to eat more and we probably need to gain weight. And as you can imagine, that can be received fine or really not well, especially if the etiology of their low energy intake is an eating disorder. And this is how these athletes might present to me. So when I'm looking at growth charts for adolescents, they may present as they had been growing normally. So you can see she had been growing normally up through about the age of 13, and then a huge drop off. So this athlete had an eating disorder. She had anorexia, and she's been in recovery for a while. As you can see, still struggling with recovery, still doesn't have her period back consistently. So she is not to an adequate weight and not eating adequate amounts of food yet. But this could be one presentation of someone that would come in with eating disorder etiology of REDS. And then this is another athlete who came in with signs of REDS as well. And so his testosterone was mildly low. His T3 was in the lowest quartile as well. And so we were pretty concerned. And then when I did his diet recall, he was not eating anywhere close to what I would expect him to need. He was a big runner, cross-country runner, running 50 to 60 miles a week. And again, at age 16 or 17, he just needs a lot of food. Had a lot of fatigue, was really struggling with completion of races and bonking at the end especially. But when you look at his growth chart, like looks pretty normal overall, like nothing, no big red flags, no big drops in weight. But he also was not eating enough. And so even in adults that come in, maybe their weight is perfectly stable, maybe their weight is increasing and they're still not eating enough. And so those are the factors that we're going to start to manipulate slowly so that they can feel comfortable with those changes or as comfortable as possible. But we can start to see metabolic changes in a positive direction. And usually that comes out with a positive impact on sport as well. So some considerations that I'm making when I'm making nutrition changes, we want to get total calorie and weight needs. And so if their weight looks okay, we're just focused on, okay, how much energy do we need for this athlete? Their weight may increase and it may not. It just kind of depends on the person and the metabolic impact that REDS has had on them. Carbohydrate needs will be 6 grams per kilo per day minimum. That's been shown to be associated with normal periods if it's above 6. And fat, we need at least 1 gram per kilo per day minimum. If they have really high calorie needs, though, it should be significantly more than that. We don't want less than 20% of calories from fat. And so I'll use, just based on the numbers and the athlete, what I'm seeing to make that determination on how much fat we need. But fat is a precursor to hormones, so we need enough fat in the diet. Also, generally, I'm looking at nutrition timing. And so if an athlete is working out for 2 hours in the morning, but they don't eat until lunchtime, they are having quite a significant period of low energy availability in the morning. And even if they're eating an adequate amount of calories at the end of the day, there's been data that shows us just moving that calories up to more appropriately around their exercise, that can also impact how the hypothalamus is responding, and get them back into a normal pattern of hormone production and kind of rectify these other things that are happening with RED-S. Food variety is huge, making sure they have lots of different foods that they're eating and aren't just restricted to specific ones. And then just generally like skills to fuel. So are their disordered eating patterns so bad that if they are at a restaurant, let's say the team stops at Chick-fil-A and they don't eat fast food, rather than just eating it because they're hungry and they need to fuel, they just don't eat it. That is negatively impacting their health, and they need a skill to be able to do that for the future, which probably involves me as well as someone on the mental health side to help figure out why they are making that choice. And then micronutrient wise, I'm looking at bone health nutrients because we know, especially if hormones have been impacted, bone health will be compromised, especially if they have the stress fracture history or if they already have low bone density. And then iron is typically compromised as well. Again, red blood cell health is not functioning normally in a red situation. And so working to provide an iron dense diet, maximize absorption as much as possible, and then supplement as appropriate based on blood work, are the other factors I'm looking at. So really my role in RED-S is I do a lot of education. I do a lot of planning and really talking about logistics and portion sizes and how much an athlete will need to have with them and when, and then identifying barriers. So if body image is a barrier to being able to fuel themselves well, we'll talk about body image. Their therapist will need to talk about body image with them, and we will need to address that in order for them to be able to be successful long term. If it's that they're worried that they're going to throw up or have stomach cramping on a race course, that's something we need to address and build trust and start to train their gut for. So the barriers can kind of be all over the place, and we're really looking individually at each athlete on how do we get this nutrition in? Are you willing to get this nutrition in from an eating disorder standpoint? How do we get that nutrition in? And then implementing it long term. So from a PT standpoint, the most helpful thing that you guys can do is really learn how to identify RED-S. So look for those common signs that were on the first slide. Use the rapport that you guys get with your athlete to learn more about them, their personality, what are their fueling patterns like. You don't need to be the dietitian, but I know you guys are having just kind of like general conversation with these athletes, and you often see them pretty regularly. And so that can be a really nice tool for you to use in order to help them continue to improve. Plant the seed that nutrition can help with recovery and performance. I will say, I rarely have an athlete without an eating disorder that comes in that doesn't benefit from our session in some way. So you can always use that as a motivator to get an athlete in and get assessed. Contact a medical provider if you're worried about more of those serious medical indications. They need to be looped in. If they're always passing out in your visits and they're never eating around your visits, that's clearly a big problem. And then again, have a trusted referral. So a sports dietitian, ideally with that CSSD credential, will be a really good resource for you. So again, questions, you can shoot me an email here. I have a bunch of resources that I think are helpful. These are just kind of general sports nutrition resources, not necessarily for RED-S, but then the RED-S-based resources are this first article, and then the second article is on the female athlete triad, which is now expanded to the athlete triad, if you want some more information on kind of where this work started. Thanks, guys. Have a great day.